So we are talking about this evening low bone mass. Now what? And I made a little rhyme: dem bones, brittle bones. Anybody that knows that reference, well done. So this webinar is we're going to talk about for about 20 minutes. We're going to talk about what happens once somebody has been found to have low bone mass, or osteopenia, osteoporosis. So that's what we're going to talk about. We are going to discuss this in the context of having found the low bone mass, but they have not sustained a fracture. Okay, so we're not really considering someone having a fracture and then found to have low bone density. This is probably more about what happens if someone's been screened appropriately and then had a DEXA scan, and then we've found that they have low bone density. What are we going to do then? Obviously, that is a slightly simpler situation than post-fracture, because obviously we need to deal with said fracture. I say we, orthopedics or someone else needs to deal with said fracture first. So we're not dealing with fractures this evening, so just take that in context as we go through this little presentation. So what we're going to do, we have a very quick overview of what low bone mass density is, osteoporosis is. Then we're going to talk about supplements, medication. We'll go on to talk about load, and then posture. And the last two are probably where a little bit of the controversy or sometimes misunderstandings and lack of awareness maybe, or specifics. That's where that comes in. So that's the really interesting part where we'll finish off, and hopefully get you some good information and whet your appetite for helping out these people who do have low bone density. So the first thing, we'll talk about osteoporosis a little bit. So osteoporosis is the progressive loss of bone density. This is typically bone mass that is lost. So the density of the bone, and therefore the amount of bone, usually within an individual bone, but you could talk about that within the body as well. So you could lose bone mass generally, but usually we're talking about focal loss of bone density. So think about places that are likely to sustain fractures: the femur, the neck of femur specifically, the radius and the ulna, distal radius and ulna, the humerus, the clavicle, those kinds of areas, the spine, particularly the lumbar and thoracic spine. We're going to lose bone density there. And what basically happens is you've got a normal amount of turnover with regards to bone within your structures. So your old bone is replaced by newer bone, and away you go. But as osteoporosis develops, what happens is the amount of bone that is resorbed is not then matched by the amount of bone that's laid down. So you get this discrepancy between the amount of bone that's taken away and the amount of bone that's put back. And so you get this loss of density, loss of bone mass, and that eventually gets you to osteoporosis. And that basically is measured against somebody of your sex at age 20. So if your T-score, or Z-score, sorry, is 2.0 or less, or it's, depending on exactly where you draw the line, it does vary ever so slightly, but if it's below that, so 2 standard deviations below the bone density of a sex-matched individual aged 20, then you are deemed to have osteoporosis or low bone density. So it's not matched against your age group. So it's not normal for your age group. It's what's normal for age 20. So that progressive loss of bone density over time, and then you have this lower bone density. Obviously, the incidence increases with age, and that's related to your ability to lay down new bone. It does decrease with age, but it's not inevitable. It's fairly uncommon prior to 50 outside of some specific circumstances. Things like low calorie intake, for example, can lead you to have low bone density earlier than the age of 50. Lots of steroids, oral steroids or whatever steroids, intake reduces your bone density, and some other causes as well can get it to below 50, but it is far less usual. It's much more likely over the age of 50, and it also occurs in our female population at about twice the rate of our male population, and this is usually post-menopause, so the protective effect of estrogen is lost, and therefore bone density, it decreases faster. So you go through that menopausal period, premenopause into the menopause, and then all of a sudden the bone density really starts to drop off in our female population, and it's really, really common in our females over 60, and that is obviously really problematic because we're going to sustain low trauma fractures, and they are, well, problematic at the time, but they also have very long-term problematic outcomes. Function and morbidity are much reduced once you sustain a fragility fracture. So that's really problematic. So obviously what we want to do is ideally we prevent osteoporosis, like we prevent that progressive loss of bone density. But in this context, as we mentioned, what we're talking about is someone's developed the low bone density. What are we going to do about that? So, the most obvious thing, I think, for me is to start supplementation of some kind. So obviously what you want is your body to have access to, quote unquote, the building blocks of bone, so the things that you can make bone out of. Obviously, if you don't have that, you cannot make enough bone, you cannot make sufficient bone. So the easiest win really is to start supplementing that. So here I've split these into two groups, medical and non-medical. This isn't exhaustive. There are other things that are helpful. Pure calorie intake for some people is very helpful. But in this context, we're going to just look at taking vitamin D and calcium in a medical format. So that would be pill-based or tablet-based. You take a vitamin D supplement with a calcium tablet, and that gives you access to the building blocks for bone. So if you are deficient in those things, you are able to have more of them. It's fairly simple. You can also get vitamin D and calcium from non-medical places as well. So through your diet, drinking lots of milk, eating lots of cheese, dairy products typically are high in calcium, and then also vitamin D by going out in the sunshine. A bit difficult in the UK, especially right now as I record and I can hear the rain pitter-pattering on the roof. We're not getting a lot of sunshine, but sunlight will do. So even if you're just going outside in the day, that can be sufficient. And the more of that, obviously, the more vitamin D you can create via your skin. So sunshine is ideal. Typically, we just need 15 minutes of direct sunshine to create enough vitamin D. Bit more difficult in the winter, as we've talked about. There is less of it about, so you might need longer in the sunlight, but it is a way of supplementing it. So if we do have people that don't go outside a lot or avoid the sun or whatever, then that is a potential way of increasing vitamin D, as well as we talked about through as well calcium through dietary intake. And then protein is a really good supplement as well, for many different reasons, muscle bulk and skeletal muscle, as well as being able to provide some of the building blocks for creating and laying down that bone, but also so that you're not taking protein from other sources within the body. So both of those situations, and most people, the guidelines, medical guidelines for osteoporosis is to immediately start supplementation, vitamin D and calcium medically via a tablet, and also if people are just osteopenic as well. So they're not those many standard deviations below normal, or a sex-matched 20-year-old normal, but they are a little bit below. Vitamin D and calcium supplementation is a good start. So that's the easiest win. So that's one thing. If that is not sufficient, so two reasons that might not be sufficient. One is that bone density is very low, or two, the supplementation is not helping to reduce that decline in bone mass. Then there are other medications that we can use, and these I would term these more of a medicine or a pharmacological intervention than the supplementation of vitamin D and calcium, even though they come in tablet form. So the first one would be bisphosphonates. And these are drugs like alendronate and risedronate. Bisphosphonates end in nate, And also zolendronate, which typically is IV given. So the first two you can take obviously at home. The zolendronate you need to go to the hospital for. So quite often that does get lumped in with the biologics. So typically people would start with something like alendronate and see what happens, and then move on to a biologic or zolendronate. And a biologic in this case, denosumab, is also available, and these really ramp up bone production. Now the problem here, or one of the problems here, alendronate specifically is disgusting. Not taken it myself, not required it, not drunk it, but patients will tell you it is absolutely foul. Gives you some real reflux as well. The other problem with some of these drugs is they can lay down bone in a bit of a haphazard fashion, so you don't necessarily get it exactly where you want it to be or even coverage. So you can in some cases get some weird atypical type fractures. So some patients might suffer mid shaft of femur fractures, for example, and that obviously again very problematic. So they aren't ideal, but obviously they are a way of increasing bone mass density, and for some people they are definitely necessary. So these more, rather than the previous page we talked about giving the person the building blocks to be able to create bone, these would help to stimulate putting the bone down, so actually creating that bone where it is needed. So on to the bit we as physiotherapists and other healthcare professionals are more interested in. We don't want to talk about those drugs. Loading programs. We've known forever and a day that loading programs are really good for stimulating bone density. So you apply force, you apply load to a bone, that stimulates bone growth, so bone density. So we talked about the turnover, it stimulates that replacement of the bone. If you're an astronaut, you go into space, there's no gravity, your bones decrease in density quite rapidly. So they have special gravity generating treadmills and bikes and stuff to get load through their bones so that they don't develop this low bone density. So we need to be providing people with loading programs. And if anybody is watching this who has low bone density, then you need to be doing some kind of loading program. So this will both assist the previous two pages we talked about, but it also will on its own stimulate bone development. So we really need to be doing it. And admittedly, I see a lot of people doing loading programs, but what I don't see is a particularly comprehensive or high enough load program. So there is obvious fear around loading the person too much if their bone density is low. And so we do need to load them sufficiently to stimulate the bone, but also missing some key components. Okay, so the first thing about these loading programs is we need them to be graded, and by that, well, I mean they need to be appropriate for the individual. So some people will be able to lift a lot, other people not so much. That's fairly obvious. It also needs to be progressive over time. You will accommodate to this load quite rapidly, as you would in any other loading situation. You lift something, it feels heavy for a little while, and then it obviously becomes easier. So we need to keep it progressive so that we keep stimulating that bone development. We need to incorporate pushing and pulling type exercises. The part that I see missed out a lot is often the spine and the lower limb are loaded really nicely, but the upper limb is completely missed off. And if we look at the likelihood of fragility fractures, we look at the most likely being the neck of femur, and the second most likely being the distal radius and ulna, so the wrist. So we need to be loading the upper limb as well. We then move into the spine being likely, but also then the humerus, so the shoulder and the clavicle. So we need to be loading that upper limb. Remember, we need to stimulate the bone development within those areas. So we need to incorporate pushing and pulling with the upper limb. And that's really important. So I like things, even in people who are reasonably new to any sort of load, then something like a wall push-up, so you're getting any load into those upper limbs to start with, and then grading it so they become lower down on an angle. or as this picture shows, some sort of overhead press, whatever it is, graded to that person, and start loading the upper limb. The other thing that is really helpful is impact. So it's been shown that sort of walking, hard walking and jogging, they really do stimulate bone growth, bone development. And you don't actually need to do that much of it. Your stimulus actually runs out quite quickly. So just a little bit of impact over a few minutes is sufficient to stimulate bone development. You don't really get a ton of development after that few minutes. So just some really quick walking up and down stairs with a bit of a stamp, those kind of things, they can be really useful as well. Just different variations potentially. And the same with the upper limb. So you can add a little bit of impact. So you can do the wall push up and then land into the wall and give yourself a little bit of impact as well. So those things are all important within the loading program. Now, you don't necessarily need to start all of that at once. You can build that up. That's this graded and progressive component. And also we want to be adding loads and external loads as we're able to. So my typical program for somebody would look like something like a squat with a holding a weight, and depends on what the individual is up to. I'll typically have them hold the weight in front of them to start with, like a kettlebell or whatever, progressing to on their back if necessary with a bar, if they need a bit more weight. Some kind of like wall push-up type movement, and then I really like a step up for that impact as well. So those kind of things, that's how I kind of tend to structure that exercise program to begin with. Obviously, people that are more advanced, then you can load them up in more of a gym-based weightlifting type motion, can be used really nicely as well. So let's move onwards to balance. So this is vitally important in our people with low bone density. So remember, their density of their bone is reduced, so their ability to resist force will be decreased. So what we want to do is have them avoid falling over. So if they're sustaining low trauma or likely to sustain a low trauma fracture, what we want to do is avoid that low trauma. So increasing their balance is incredibly important. Where do I see the errors come in here? Now, what I typically see will be a lot of static balance exercises. So we're going to see things like standing on one leg or tandem standing, and typically it's not that useful. It's not as useful. We want to have a good dynamic balance. People are mostly moving around and doing stuff. And so, of course, what we want to do is again, have it graded. So what is this person's balance like? And there's various measures for that. But we want to challenge them. And then we need it to be progressive over time. So we need to improve their balance. So really getting them in and challenging their dynamic balance. So I'm talking about balance moving. In previous times have had them doing sort of slalom type movements, or walking at bent legs, or changing direction, dynamic change of direction, speeding up, slowing down, those kinds of changes, but also up and down slopes. And the other thing that they really need here is relevance and environment. So where are these people likely to fall over? Okay, so if they're perfectly safe in their house, but more likely to fall outside, then they need to be doing some of these exercises outside. So we need to challenge their balance outside. There's lots of differences. Wind, rain, inclement weather is particularly prevalent now. Other people, is remarkable how much your balance is challenged when there's other people around. So you might need to take these people out into the community and challenge their balance elsewhere where they are going to go. It doesn't have to be necessarily the exact environment where they're going to go, but in a similar type environment, so that they're challenging that balance, and when they go to that environment, they're then they're ready to be able to accept that challenge and not fall, because that's what we're aiming to avoid. Obviously, if they are of a higher ability, then you might want to incorporate things like hopping, jumping, again, changes of direction, changes in speed, that kind of thing. So really challenging them, really focusing them. And I would incorporate a balance component regardless of the age of my patient, to try and avoid them from falling. Okay, posture. Here is probably the most controversial component. So there's a lot of guidance. All the guidance about osteoporosis talks about posture and how we should educate on posture and what that means. Now, do we know how much force is going to go into the anterior portion, the front of spinal vertebrae when we flex? Yes, there will be force applied to the anterior part of the vertebral body. Now, does that mean they're more likely to sustain a wedge fracture or a fragility fracture of their spine? That's a more complicated answer. When do they go into flexion? Can they avoid going into flexion? Probably not. Lots of studies, kinematics type studies, show doesn't matter what you do, your lumbar spine is going to flex if you bend down at all. If you're going up and down stairs and you're lifting your hip up, you're going to get some flexion. So can we avoid flexion entirely? Absolutely not. Is it functional to avoid flexion? Absolutely not. We need to be able to get down to reach our shoes, our socks, the floor, get in and out of baths, of showers, in and off the bed, so on and so forth. So I think teaching to avoid flexion is problematic. We need to teach people to be stronger into flexion. And would I load someone, I've put a picture of a deadlift here, would I load a heavy deadlift with a person who has never done deadlifts before, who has been shown to have low bone density? No, I wouldn't. Would I develop towards it? I probably would. Have they ever got to lift anything from the floor? Shopping, whatever, grandchildren, etc. So do we need to actually load into flexion a little bit? Probably. Do they need to avoid flexion entirely? Probably not. Do we need to overload flexion into something ridiculous like a Jefferson curl? No, of course we don't. So we just need to be careful what we're saying and what we're doing with these patients, and making sure we're not giving them any fear-based narratives. There is good evidence now, multiple studies. The Liftmore study out of Australia showed quite heavy lifting in people, older females particularly, with low bone density, and they had no reports of adverse outcomes, so no fragility fractures. Good study using kettlebells and kettlebell exercises, again loading quite significantly. So we can be quite confident with the safety of these loading profiles as long as we're relatively sensible. I quite like to load extension, and I'll start that by loading the posterior chain. Pardon me. However you deem that appropriate. Typically, I'll use something like a squat. I won't start people off with weight on their back because of the balance aspect. I'll tend to have it in the front, holding in the front, but I will at some point want to progress to it being on their back. Now, whether that's a rucksack or a true bar, whatever it is, I want to load that posterior chain so we've got nice, strong extension so that we're not coming forwards. Now, this is problematic with regards to posture, is people going into sustained flexion, their posture coming into sustained flexion, and you'll all, I assume, have seen people with multiple wedge fractures who end up in sustained flexion. That's what we want to attempt to avoid. So any strength where they can keep their posture into extension is going to be great. And of course, relate it to comfort. We don't want people being stuck in specific postures for an extended period of time. They might find one posture more comfortable than another. So we just got to work with people on what's going to be the best. I see things which are really fear-based, don't sit in flexion, so on and so forth. There's just not enough force in there. I wouldn't be worried about that. We just need to avoid those fear-based narratives. So we'll move on to any questions that we have here on the webinar live now. Hopefully you found that useful. A bit of a whistle-stop tour of what we want to do with people with low bone mass. I am planning on doing a few more webinars on this where we might dive deeper into some specific aspects. I'm potentially going to lose my voice in a minute, so let's check, have a look, see if we've got any questions. I'll give you a minute or so to pop questions into here. Otherwise, we will sign off for the webinar for this evening. I'll just take this opportunity whilst people are typing questions, should they be typing questions into the chat bar, to say there are plenty of other resources on my website. Just go to rheumatology.physio. I've got lots of other webinars on the YouTube channel as well. So if you, again, type rheumatology.physio into YouTube, lots of webinars. Also on the website, I've got a shop as well. If you want a full in-depth courses, then you can come see me in person or online as well. So Q&A function's a bit quiet this evening, so I'll let people put those in. You can find me on social media, you can find me by email. Anything you want to do, you can find me by rheumatology.physio. So I'll let you go for this evening. Hopefully you've enjoyed that. And I will be running another webinar at, I think, at the end of the month. Haven't decided on what topic yet, but I'll be in touch with regards to that. And we will go from there. We have got a question here about how long can people remain on alendronate for. So this is an interesting question. So used to be that they would stop people after 5 years being on alendronate, and that was to give them a break, but that's a bit more flexible now depending on what their bone mass density is doing. The guidance has been relaxed a little bit on that, so they can go on alendronate for longer, but typically what they'll do is review it 3 and 5 years and see whether the bone mass is improving or not, and if it isn't, then reconsider whether alendronate is an appropriate drug. Okay, lovely stuff. Thank you very much, everybody, for joining me. Hopefully you found that useful. I'll see you out on further webinars. Have a good rest of the evening. And I shall see you soon.